Assalamu alaikum, everyone. Welcome to the neurosurgical case room. And today we continue the clinoidal meningiomas from where we left them off the day before yesterday. Am I audible? Am I audible? Okay. So, is there a need for me to go over the anatomy or anything else from the day before yesterday's session? Because if you do not remember the anatomy, it will be really difficult for you to understand the surgical steps. Okay.
It was clear, Dr. Kaval.
Okay, then let's start. So Dr. Shahana is saying, please repeat the anatomy. Okay, it was a good idea if you could have listened to the previous session's recording so that it was easier for you to connect today. Let's go back very briefly and see where we can go over quickly because it's going to take a lot longer today if I go over anatomy in detail. So this is the bony anatomy, and you can see the anterior clinoidal process. On its medial border, we have the optic canal. On this side, laterally, we have the superior orbital fissure, and slightly above here, where my cursor is right now, it is going to continue with the lesser wing of the sphenoid bone. And on this side, we have the planum sphenoidal. Whereas if you see in the beginning, in the middle, we have the sella, the hypophyseal fossa, and the posterior clinoidal processes, which are not visible here. And you can also see the anterior clinoidal process. So just take a look at it again, because if you remember this picture, it's going to be a lot easier once we go over the steps of anterior clinoidectomy. You can see that we draw here. This is the anterior clinoidal process. This is the optic strut. Optic strut is a bony bar which connects the anterior clinoidal process to the body of the sphenoid bone. And here we have the optic canal. This is the roof of the optic canal. We changed the color. This here is the roof of the optic canal. And this here is the sort of the floor and the lateral wall of the optic canal, which is made by the optic strut. And optic strut also separates the superior orbital fissure, which is here in the orange. The superior orbital fissure is separated from the optic canal with the help of optic strut. So what ends up happening, once we do the anterior clinoidectomy, we take up this whole thing. And if there is compression over the optic nerve, then we also remove roof of the optic nerve, optic canal, and the optic strut as well. So the bar or the chunk of the bone that I have covered in white, this is what gets drilled usually in the anterior clinoidectomy. Remember that please give me a minute. Okay. Remember that decompressing the optic canal is a surgeon's choice if the tumor has not directly invaded inside the optic canal. There is no reason to, but MEFT is in favor of decompressing the optic canal. Nonetheless, opening up the dural sheath of the optic nerve and tracing down the tumor, if there is, even if there is the tumor is not there, then he still ends up opening it. So this varies from surgeon to surgeon. What I have seen in the clinical practice in my institute was only taking up the anterior clinoidectomy, the anterior clinoid, and not the roof of the optic nerve if it was not deliberately needed. What are some other structures which are going to be here? Let me clear this up. There is going to be a meningo-orbital band which attaches here extradurally, and we have the temporal dura here, we have the frontal dura over here, and there is this band that is attached to the anterior clinoidal process, and we end up cutting that band right from here. Once we cut it, this band contains the meningoorbital artery, and the meningoorbital artery is also one of the blood supplies of the clinoidal meningioma. We are going to come to the steps of the surgery later on, but it was an interesting point, so I wanted to add it to the anatomy. Let me move to the next slide. So, just a brief reminder, optic nerve is immediately medial. Internal carotid artery sits directly beneath the process. Superior orbital fissure is lateral. And anterior clinoidal process intradurally is an attachment point for tentorium cerebelli. This is the sagittal view. And this is slightly posterior to where the anterior clinoidal process was. And you can see here that on the medial side of the anterior clinoidal process, we have the ICA, and this ICA was extradural. This is something that we discussed in detail in the previous session, that the ICA, which is behind the anterior clinoid process, the clinoidal segment, this is extradural. What does it mean? It means that once we take this off, once we take the anterior clinoidal process off, we get access to extradural ICA directly, and this ICA is the clinoidal segment, right?
Yes.
Let me move. So this is a brief overview, a very simplistic illustration to make it clear, and you would have some idea of what structures are going to get involved if there's a lesion in this region. For example, the lesion is here. You can see cavernous sinuses. You can see the pituitary and the infundibulum. We have the optic chiasma here. There's going to be ICA somewhere here. Third nerve is going to be there. Second nerve is going to be there. So these are all the structures that get involved once a patient has clinoidal meningioma that grows out significantly. I'm going over this because we are going to come back to it again. This is anterior clinoidal process, and this is the anterior clinoidectomy, and it shows the steps that I previously described in a very beautiful illustrative manner. You can see that this surgeon has unroofed the optic canal here, and this anterior clinoidal process is also cavitated like a shell. And once that is removed, then this strut is the last portion which is removed. Hence, this entire optic nerve is now free. It's completely decompressed. It has a lot of space. Along with that, once we are retracting the temporal lobe, we will get significant space around around the notch, which was previously a very tight area. Let me clear and move on. So you just see those steps. Let's go. Just take a brief look at the classification. Type 1 was where the ICA entered the dural ring. So this here is the extradural portion, and if there is a tumor, which is type 1, there is no arachnoidal separation between the lesion and between the ICA. Why? Because the ICA is still extradural. It does not have protective covering around it. So any tumor that is here in this region, type 1, is going to attach itself directly to the adventitia of the ICA, and a gross total resection will not realistically be possible. Type 2 is on the superolateral aspect of the anterior clinoidal process. And if this grows out, it's either going to grow laterally over the lesser wing of the sphenoid, or it is going to cause compression over the temporal lobe and cause seizures. The other presentation can be hyperostosis of the anterior clinoidal process, hyperostosis of the orbital wall or the optic canal. So type 2 can have variable presentations. Type 3 classically occurs at optic canal itself, and because it is in such close vicinity of optic nerve, it is going to present with sudden vision loss or early visual disturbances, which will lead to earlier presentations. Type 3 tumors are characteristically smaller in size, and they're diagnosed earlier as well. Let me just take a brief look at this image, and then we will move to the topics today. So this is anterior clinoidal process, and you can see that this is the distal dural ring, this is the proximal ring, this region here is extradural. So if there is any tumor in this region, which is type 1, then it is going to attach itself directly to ICA, and there's going to be stenosis, and ICA is going to be involved with the lesion without any arachnoidal layer in between. Move to the presentation. So, how do they present? I believe we did discuss presentation of clinoidal meningiomas in a very brief manner in the previous session as well, but I thought that probably there should be a dedicated section. So visual impairment is obviously a very common consequence. Why? Because the lesion is going to be in the vicinity of optic nerve and optic chiasma both. So now the location decides what kind of visual impairment there is. Usually there is unilateral decrease in visual acuity, and there can be visual field effects, most commonly present as ipsilateral scotoma or temporal hemianopsia, or a patient can have bitemporal hemianopia as well if there's optic chiasm involvement. Then optic atrophy. And what kind of optic atrophy? Primary optic atrophy, because there is direct compression on the optic nerve. This atrophy is not because of raised ICP and long-standing compression over the disc. This atrophy is direct compression, right? So this is primary optic atrophy, and you can easily find it on fundoscopic examination. Besides, since we did do all the previous structures, we know that within this tumor's vicinity, we have the superior orbital fissure, right? And the carinous sinus, which means that this tumor can involve the third nerve, the fourth nerve, the sixth nerve, V1 and V2. This involvement can happen in the carinous sinuses. It can also happen inside the superior orbital fissure. So that is a realistic possibility that a patient will have ophthalmoplegia and diplopia once they present to us. And then we will have to localize where the involvement is. Then patient can also present with ptosis, compression of the oculomotor nerve, and trigeminal symptoms as well. If there is ophthalmic involvement, then patient can have the facial numbness and uh, pain. Referred pain can also be a symptom. But usually, the more common presentation is decreased visual acuity, field effects, ophthalmoplegia, and ptosis can be there as well. Headaches, obviously, due to raised ICP, due to mass effect. Then we have the proptosis. Why proptosis? Because once the tumor invades the orbit, there can be hyperostosis. And hyperostosis of orbit is going to push the eyeball outside. So this is going to be extraconal proptosis, and the patient might also have extraocular movement paralysis as well simultaneously. So once we have a patient with proptosis, I think you all know that medial sphenoid wing meningiomas and clinoidal meningiomas are significant DDs if a patient has unilateral proptosis with third nerve palsy. So Foster Kennedy syndrome is more of a concern in the olfactory group meningioma, but this can also be a very rare presentation for clinoidal meningiomas. There can be ipsilateral optic atrophy and contralateral papilledema. I think we discussed this in the previous session. I don't know, or maybe I discussed it with someone else. Foster Kennedy is only going to happen when the lesion has unilateral growth, when the lesion is growing more on the one side and it is big enough. If it is growing, let's see, this is the anterior clinoidal process, this is the other anterior clinoidal process, this is the lesser wing of the sphenoid. Please excuse my very poor drawing. Then we have a lesion here. For example, this is a big lesion. It is engulfing the anterior clinoidal process. and now it's unilateral. It's not crossing the midline as of yet. It's not involving the other optic nerve directly. It is only causing direct compression over this side of the lesion, and now this is growing big and bigger, and it's big enough that it is causing significantly raised ICP or hydro, which ultimately leads to papilledema. So this is the only scenario in which you will find that there is optic atrophy on one side and there's contralateral papilledema. But if you're an exam candidate, I would leave a PS. It's wise enough to not mention Foster Kennedy syndrome while you're discussing clinoidal meningiomas. But yes, you can always say that there can be ipsilateral optic atrophy and contralateral papilledema. That is justifiable. Seizures. So I'm regretting that I removed. Let's go back. Yes. Let's clear this. So please bear with my very poor illustration. There is temporal lobe here as well, right? We know that this lesser wing of the sphenoid is actually a boundary of the middle cranial fossa, and this here is the middle cranial fossa, which is housing the temporal lobe. So what ends up happening is, if there is direct compression over the temporal lobe by this lesion here, then there can be cortical irritation, and due to compression, these lesions can trigger seizures as well. Similarly, if this grows superiorly and there's compression over the frontal lobes, that also predisposes the patient to the seizures. Am I clear?
Yes.
Okay, moving on. Surgical excision. I believe this will be really, really easy for everyone who attended the day before yesterday's session, because this is nothing but all the anatomy that we discussed previously. So the incision is, it's typical. The curvilinear unilateral incision we use for pterional or modified pterional approaches, and this is the pterional craniotomy. Now, there are certain variations that you can have once you're approaching the clinoidal meningioma, depending on how big it is. Let me draw here. So if this is a clinoidal meningioma, which is not involving the sella, and you believe that you would be able to access it from a pterional craniotomy, then this craniotomy is fine on its own, because what are we going to do? You see this ridge here? This is the lesser wing of the sphenoid. And what we do is we ronger this off completely. While we are rongering it and we're going medially towards the midline, then ultimately we end up reaching the anterior clinoidal process, and we do the drilling and we take the anterior clinoidal process out. So the goal is, clear this, the goal is to create a space here, and for some surgeons that is more than enough. Now, Mefti has another opinion. Mefti says that for it, it would like to take the supraorbital ridge of the orbit along with some portion of the frontal process of the zygomatic bone. This is zygomatic bone, right? And this is the frontal process of the zygomatic bone here, which is forming the lateral wall of the orbit. So Mefti does this thing, and then it takes this as a separate osteotomy. So what ends up happening is, now you have a wide exposure, because part of the orbital roof and part of the ridge, which would have blocked your view otherwise, is now out of the way, and you get a direct access to quite the midline. Even sella, if there is sella involvement, you can still reach from this craniotomy. This is good enough. Let me move to the next slide, and I'll show you what other variations can you do. So you can do a modified pterional or extended pterional approach. You can do a pterional approach with orbital osteotomy. You can also do an FTOZ approach, a frontotemporal orbitozygotomy is a zygotomy, if you want access to sella and there is extensive involvement. Clear this. So this is the typical boundary of the Mefti, which it causes, which it calls extended pterional craniotomy. You can see that they have taken the orbital ridge and the frontal process of the zygomatic bone. This is an FTOZ, and the only difference is you get to take slightly more of the ridge and you take part of the zygoma along with it. You can do it in two parts. You can do it in a single part as well. That completely depends on the surgeon's preference. FTOZ usually has the benefit of cellular exposure. And if the tumor is invading the cella and you think it would be really difficult with a standard craniotomy, then you can extend it to the FTOZ. Clear this? I believe that all of you would be very, very familiar with this image because this is where we do the craniotomy usually for the, this is how we do the decompressive craniotomy as well. I am not talking about the frontal or the parietal or the temporal margins. What I mean is that this is a commonly operated area for us, and this here is the lesser wing of the sphenoid. So once we have done the craniotomy, we need to rongeur this ridge. I was regretting today that I don't have any pictures from when we used to rongeur this. So we rongeur this off, and you see that this space is quite narrow because this bridge of the bone is butting in and it's creating this tight space between the frontal and the temporal lobe and the anterior cranial fossa and the middle cranial fossa. There's a very significant demarcation and the space is tight. So once you end up drilling this, imagine that we have taken all of it out and we keep going deeper in. From the surgeon's point of view, you are going deeper. But from the anatomical point of view, you are going towards the midline. Am I clear? Am I making sense here?
Can you please repeat that?
Okay, which part? The rongering part?
Yeah.
Okay, so once we do, let me go back to the previous slide. Let's see. You're familiar with this, right? We have done a pterional craniotomy. And once we have done a
Yeah.
pterional craniotomy, you would have seen this ridge poking out, right?
Yeah.
So up above this ridge, we have the frontal lobe and the frontal dura and the anterior cranial fossa, right? Because this is all skull base. And here we have the middle cranial fossa and the temporal lobe and the dura of the temporal lobe. Are you with me till here?
Yes.
So this is the lesser wing of a sphenoid. It pokes up like a ridge and it creates this bony separation between both these. This is the frontal lobe, this is the temporal lobe, and this leads to a very narrow space. Once you end up taking all of this bone away, imagine that you have cut this bone off. Now this space is going to be empty. And because it is empty, you will need a lot less retraction than you would have otherwise needed. Am I clear here?
Yes.
Okay. Are you still a resident?
Yes, this is final year neurosurgery.
Okay. So the next time you do a decompressive cranectomy, take a really good note at this ridge which is poking out. And maybe if you have a senior around, you can try rongering it. It's not going to do any harm to the patient. You just have to retract the dura and you have to ronger off this lesser wing. All it is going to do is slight bleeding that you can pack with the spun and gauzes, and it's going to be completely fine. But this technique significantly improves the space around the middle cranial fossa. What ends up happening is when we are doing anterior clinoidectomy, we go this way. If I am talking from the surgeon's perspective, I'm looking at it as a surgeon, then I'm going inside, right? I'm going inside these both lobes. But if I'm looking from the anatomical perspective, then I'm going towards the midline because we are looking at it from the lateral side, right? Is that clear now?
Yes.
Okay.
Yes.
So
This
once we end up going deeper, which is towards the midline. Following my arrow, we are going to come across anterior clinoidal process, which is nothing but a bony projection of lesser wing of a sphenoid. Okay, and change the color. This is the anterior clinoidal process. What ends up happening is, even extradural, there is this meningoorbital band which gets attached. This hidden behind my. You see this cut here? So this is meningoorbital band. This is a thickened dura. It's nothing but thickened dura, and it gets attached to the anterior clinoidal process. And what it does is, it keeps the frontal and the temporal lobe dura closed. So once we cut it, clear this. Once we cut this off, now the temporal lobe along with its dura can be retracted and the frontal lobe can be separated slightly. So we end up creating more space. What is our goal? Our goal is to create more space. Then we do the extradural drilling of anterior clinoidal process here. How do we do the extradural drilling? Can someone repeat from yesterday?
From diamond bit.
Yes, from a diamond bit. Why? Because it is atraumatic. It's not going to catch dura. And why is that important for us? It is important because
Safe
what was,
diamond.
yes, there is lesser space. And what was behind the anterior clinoidal process? Two very vital structures. What were those?
ICA and optic nerve.
Yes, extradural portion of ICA, the clinoidal segment of ICA, and the optic nerve. So if we end up injuring the dura anywhere around this, the consequences are going to be unbearable for the patient and for the surgeon both. So let me clear this. I'll show you the technique. This is taken like an eggshell. You thin it out. You thin it out to a point that there is a thin layer of bone which is left on the ICA, and then you gently peel it away. You never ronger it completely because you don't know whether ICA is adherent to it or not, or there's an anomaly or anything. The safest approach is to thin it completely till there's a very thin layer of bone left that can be taken with the help of rongers, and then you take it bit by bit gently away from the ICA. And once you have taken this away, you're going to see extradural clinoidal segment of ICA directly, and you're also going to see optic nerve. Let me move to the next slide. It will make it clear. So this is a cadaveric image, and you can see how beautifully they have drilled this entire ridge. You do not see any ridge here. Can you appreciate this space? This is bigger than what it looks. Who's this? Please unmute yourself. Please unmute yourself. Unfortunately, I cannot access the participants panel anymore for some reason, but please mute yourself. If you're familiar with this particular approach on human patients, then you would realize that this is a lot more space than it is present in a normal human being because the ridge has been rongered off. It's completely flush. The floor of the anterior cranial fossa and the middle cranial fossa are in continuity. You want to see that? You can see this here. This is the anterior cranial fossa. This is the middle cranial fossa, which they are calling temporal fossa. They're same things, obviously. You can see that there is relative continuation between them. So once we do that, we reach here, there's this meningoorbital band. They have cut it here. Once you cut it, you can see that now this temporal dura can be retracted a lot more, and the frontal dura can also be retracted towards this side a lot more flexibly. And it is going to create a lot of space in this region where there previously wasn't much. Are you all following me?
Yes.
Yes.
So now, once we have done this, we clearly see the anterior clinoidal process here, which is right here. Let me mark it. This is the anterior clinoidal process. Once you drill this away, I'm going to show you the next image, which will show how optic nerve and ICA would look like. Just give me a minute. I need to see who this is with the unmuted mic. Dr. Yese, please mute yourself. Okay, coming back, we can see that there is anterior clinoidal process. We take it out. Once you have taken it out, in this image, you do not see an anterior clinoidal process, which would have been here. And then if you retract the temporal dura, on the base, you're going to find Gazerian ganglion and the V1, V2, V3, but that is not our goal. We are not concerned, so we are not going to retract temporal lobe like this. What space are we concerned with? We are concerned with this region, here only, because our target is going to be here. The lesion is going to be exactly here, and all the vital structures that we are concerned with, they are also here. So this is again the same curvilinear incision. Then we have the bony exposure. Then we have the craniotomy here. And after the craniotomy, please ignore this. They have just stripped the dura to show how Gazerian ganglion looks like, and V1 here, V2 here, V3 here. We are not concerned with this. This is something you would only see if you are retracting the temporal dura and you are peeling the dura on the floor, which is not our goal. Our goal is somewhere here, where the anterior clinoidal process is. So once you take this away, like the way we were drilling, look at this. This is beautiful. So once it, and by the way, this is an illustration of intradural clinoidectomy. We are discussing extradural clinoidectomy. Why? The reasons we have already discussed in the previous session. This here is the clinoid, and once you take it away, see, they are taking it away, you're going to see this clinoidal segment of ICA and the optic nerve. They have also unroofed the optic nerve, by the way. Move to the next slide. So this is again an illustration. You take out the anterior clinoidal process here. Once you take it out, you have a clear view of internal carotid artery, the clinoidal segment, and the optic nerve. The superior orbital fissure is just below and lateral. So we also have to take care of not injuring the third nerve. If you focus on this portion and ignore all of it here, you will see that there is a very small ICA hiding right behind here. And along with it, there is the optic nerve and third nerve in its dural sheath. So once we have done the extradural anterior clinoidectomy, what is going to be our next goal? We are going to open the dura like we normally do, raise a flap, base it towards the base of the skull, and then we slightly retract the frontal lobes. But once you have created so much space, you are not going to need a lot of retraction. The goal of all this work that we were doing extradurally was to create space so that we will not need fixed retractions. You can see, once you take out ICA and you zoom in from your microscope, you're going to see this ICA here and the optic nerve right behind here. This is an intradural view, by the way. Let me clear this up. Oh, and interestingly, in this image, you can also see basilar artery here and the superior cerebral artery here, because anterior clinoidectomy is a very versatile surgical step, and it is used widely for aneurysm surgeries as well. It is used for ICA aneurysms, and if you take out anterior clinoid and posterior clinoid as well, then you can access basilar artery aneurysms and the superior cerebellar artery, PCOM, etc. So this is an approach that every neurosurgeon should know. After all of this, the only step that is going to be left, which I could not find, good pictures for was once you open the dura, you are going to see the tumor and you will gently retract. See if it needs, if the sylvan fissure needs to be opened. Otherwise, just leave it. Since you have already taken out the meningo-orbital band, the tumor has already been devascularized. So you're going to follow the meningioma principles, devascularize, incise the capsule, do a central debulking in the core, and afterwards, after you are done with the central decompression, you just let the capsule collapse on its own and gently peel it away from all the structures, not including ICA. If the capsule is adhering to ICA and there is no significant arachnoidal layer, then you just do a subtotal resection. You do not attempt a total resection. This is just everything that we discussed in the text. Patient is in supine position, head is rotated to the contralateral side, and incision is a standard curvilinear scalp incision, the unilateral or the incision that we use for pterional approach. So MEFT calls it frontoorbital craniotomy, and it is also extended pterional. There are authors which call it extended pretemporal approach as well. Orbital extension is a surgeon's choice, but it also varies from case to case. If there's suprasellar extension or sellar extension, then you might need FTOZ as well. So your flap, your skin incision should be big enough that if you feel that you are going to need this extra exposure, then you can easily do that. And yes, all the extradural work we do, the goal is to minimize the use of retraction. So then we have the dural dissection. We gently peel away the temporal dura and the subfrontal dura away from the sphenoid wing and the posterior orbital roof. Then we do the sphenoid wing resection. After the resection, we cut the meningo-orbital band. Remember this name? This is meningo-orbital band. It attaches in close vicinity to anterior clinoidal process and superior orbital fissure, and it has meningo-orbital artery, which is also a significant supply to the tumor. So once you cut this and you disconnect, then this artery is also obviously cauterized and the tumor will be devascularized early on in the surgery. Moving on, we do an extradural anterior clinoidectomy. Afterwards, we devascularize if there is any significant supply from middle meningeal artery, etc. And we have already exposed the clinoidal segment of ICA once we did the anterior clinoidectomy. The intradural phase is easy. We open the dura, easy to say, not easy to do. Dural opening. After the dural opening, depends if you are going to need the sylvan fissure dissection or not. It will depend on the morphology of the lesion and how deeply it is involving MCA branches and the sylvan fissure. If there is no significant involvement, then you would not need to open the sylvan fissure, but you should know that that is also a technique. You are going to open it from Lehman insula to visualize the middle cerebral artery course. The tumor debulking principles stay the same. You devascularize, you incise the capsule, you debulk it from the core and let the capsule collapse on itself and then gently peel it away from all the adjacent tissue and the vessels. Once you have taken the tumor out, now the skull base needs to be reconstructed. And for that, you would need either a fascia lata or you can use a periosteal flap. You can also use the synthetic dura. Depends on the surgeon and on the institute and available facilities as well. One important thing is, if you find that the bone is hyperostosed, you would need to drill it, obviously, but while you're drilling it, a really important thing to remember is irrigation, because A, it's going to produce a lot of bone dust, and B, drilling produces significant amount of heat, and heat is one of the most important causes of optic nerve injury. Even if the nerve is completely intact anatomically, if it had thermal injury, patient is going to have visual deficit postoperatively. Then the optic canal decompression, we have already discussed it. If the tumor is extending inside the optic canal, then we can take the roof off. We can also take the optic strut off and open the dural there and address the tumor extension. Along with that, if you have dealt with the vessels, then it's a good idea to drip the solution of piperine so that the vessels do not go in the vasospasm. Just because we handled them or just because we were working in close vicinity. The extent of dissection and resection we have already discussed. Type 1 tumors are not going to give you an arachnoidal plane, so they are inseparable from ICA. You cannot do a GTR. Dural repair is mandatory, otherwise patient might have CSF leak, especially if anterior clinoidal process was pneumatized or if the optic strut was pneumatized. You fill that space with abdominal fat to obliterate it. We discussed it yesterday, so I'm not going in the detail for that. And then we seal everything with the fibrin glue. So coming back to the steps, if assuming that ACP was pneumatized, then we put the abdominal fat in it. We place the periosseal flap or the fascia lata, and then we reinforce it with the fibrin glue. And post-operatively, we are going to avoid lumbar drains because if the skull base reconstruction is good, CSF leak is not going to be a problem. Was it clear? Was it all clear, or did it feel like a roller coaster or something?
It's clear, Dr. Kawal.
Thank
Okay.
you.
Thank you. Since we covered anatomy and certain surgical maneuvers in thorough detail in the previous session, and the goal was to make this one brief, even though this has not ended up being brief. But I believe if you go back and listen to the previous session as well, and then this one, you're going to be pretty clear. Even if you have questions afterwards, or if something is unclear, you can always leave questions on the group and we can rediscuss it. Let's move on to the complications very briefly. Cerebral infarction, secondary to injury or vasospasm. We just discussed that. Sometimes we do not end up injuring the vessels directly, but what happens is once we are maneuvering the lesion and the tissues around it, the vessels can go into vasospasm, and hence perioperatively we use piperine solution to prevent the vasospasm. Hemorrhage is a real possibility during surgery. Obviously, we are working in the vicinity of ICA. It will be a nightmare for any surgeon, but that is a possibility. Then infarcts, small infarcts. If you're in the cellar proximity and you end up taking the hypophyseal branches, they're very small and they supply the infundibulum. So you might think that these are some small perforators and you end up using bipolar without much concern, then the patient is going to have DI postoperatively because hypophyseal arteries are crucial for infundibulum and for the pituitary capsule. Along with that, CSF rhinorrhea is a possible complication. We discussed it previously. Seizures are a complication, meningitis, visual and cranial nerve deficits, which we are going to see in detail. So why visual deterioration? Your patient had okayish vision preoperatively and you operated and you are 100% sure that there was no injury to optic nerve during the drilling. But the patient still ends up losing the vision or the acuity. The cause is going to be thermal injury from high-speed drill, and probably the assistant did not use enough irrigation. So that is going to be a really big problem. Hence, the intradural anterior clinoidectomy is avoided for this particular region. If the anterior clinoidal process is hyperostosed, Like this. If it is hyperstored, then a very good idea is to never do the intradural drilling because it will produce a lot of heat and a lot of bone dust. Bone dust is going to cause aseptic meningitis. Heat is going to cause thermal injury to optic nerve. So ischemia of the nerve due to damage of the ophthalmic or the superior hypophyseal arteries, and I also mentioned the superior hypophyseal arteries can supply the infundibulum and the pituitary capsule. If infundibulum is damaged, then the patient can have DI postoperatively. Ophthalmoplegia is a real possibility, especially if you have gone near the cavernous sinus or there was any injury around the superior orbital fissure. So this is a wrap, and I'm happy that we concluded it today. It was a long topic, interesting but long. All feedback, all questions, they're welcome. Watch them in tandem. I'm going to share the. Okay, so Dr. Vikas is asking how about taking control of cervical ICA for. Yes, Dr. Vikas, that is a technique used by certain surgeons where, they expose the cervical ICA to maintain the proximal control when you are dealing with the type 1 clinoid meningioma. So it is a possibility. There are surgeons who do this, and it's a real approach, but not something which I think is advisable at our level. I think it would be a better decision to do a subtotal resection instead of, compromising the cervical ICA. But then that depends on the case and on the surgeon and surgeon's expertise as well. There are certain Indian surgeons who have been doing this technique, not only for clinoidal meningiomas, certain other meningiomas as well. Is that clear? Okay, so thank you so much, everyone. If there is any other question, please leave on the group. I will surely get back to them. Thank you. That's a wrap. And we will have the next session on the Monday. Let me think. I was trying that if we can arrange the next session on Sylvian Fisher anatomy and then the Sylvian Fisher dissection, splitting everything, because we were in the vicinity, we were doing clinoidal meningiomas. So Sylvian is going to be the next natural continuity. Let's see. I will announce the topic on the group, inshallah. Thank you so much. That's a wrap.
Thank you.